So I'm here in Shanghai at this amazing venue with our China editor, Yao Zhu from Fudan University Shanghai Cancer Center. Yao, thanks for inviting us to your home here in Shanghai.
Yes, we are glad to have you, Declan, here and to join this, the whole new buildings. And we have a very large meeting and we have very well-known international guests. It's glad to meet you in Shanghai.
It sure is, and we're here in this beautiful room. We're at the back of the auditorium. It's the 14th annual GU Oncology Meeting of Fudan University. There's about 1,000 registrants, and you can see this beautiful stage behind me. We could learn a lot of lessons about how to run conferences by coming here to this meeting. And as you say, we have some international guests, and we're going to chat to them in the podcast. And your colleague, your boss at Fudan University Shanghai Cancer Center, Dingwei Ye, is going to join us for a chat on the podcast as well. But it's been a great conference already, hasn't it?
Yeah, so we are really honored to invite you and many international guests here to China.
Yeah.
And in this meeting, we are fortunate to hold the MDT debate and the surgical innovation session part to discover the advance in prostate cancer, bladder cancer, and kidney cancer. And interesting point is that this meeting is one of the largest GU oncology meeting in the mainland of China.
Yeah.
So every year we will invite international experts like you and other from the European or the United States to come to here and to discuss about the exciting data and the new advance. So it's really great to meet in December and to summarize what we found in the 2024 and what we are looking forward in the next year.
So we're going to put together 2 quick podcasts of conference highlights at this meeting, supported by our gold partners, Bayer China, who've been great in supporting these themed podcasts for China and supporting all of our conference highlights podcasts. So we're going to track down the 4 international guests, myself, Axel Merseburger, Karim Fizazi, and Steve Freedland. So absolutely great guests talking mostly on prostate and bladder cancer. And we also have some local Chinese guests as well. So we're going to have a quick chat with them about what's hot in oncology here. So stay tuned. We've got part 1 coming in this episode, and then we'll be back with part 2 very soon thereafter. Thank you. So I'm here with Professor Dingwei Ye, who's the chairman of this fantastic conference that I've had the pleasure of being here a few times before. And he's also a urologist and director of GU Oncology at Fudan University Shanghai Cancer Center. Dingwei, thank you so much for inviting me back to your fantastic conference.
Very nice to meet you again.
Yeah, it is great to see you. You're a friend of GU Cast. We've interviewed you on the podcast before. I recall when we were at APCCC in Milano just a few months ago, you spoke to us. But first of all, I want to congratulate you on this. It's the 14th version of this GU Oncology Academic Conference. It's also an official meeting of the Chinese Anti-Cancer Association, GU section. So tell me a little bit about why this is such a special conference.
Okay. This is the 14th GU Oncology Shanghai International Forum. And this is the very special moment. I just remembered it's 14 years ago, including Declan, you just joined us, right? And right now, more and more international speakers just join us this time, especially very important international, key opinion leaders to join us to just share the international view of the latest informations. And the second is this is just after COVID-19. This is the first time we met so many Chinese colleagues together and all international colleagues together. This is the fantastic moments, and this is the academic party. And third, I want to highlight is we just West and East meet together, and also area national colleagues from the GU Oncology, including the urologist, also the multidisciplinary team members like a pathologist and also medical oncologist, radiation oncology, not only the surgeon together, we just MDT together. This is the point I want to highlight. This is a wonderful conference.
Well, I first came to this conference 10 years ago, and I remembered throughout those years you were constantly reinforcing why multidisciplinary care matters. I mean, we all know that, but it was also important to create some awards and some documents to support this in China. And I see it now in 2024, these teams working really well together here. And I think, yes, for me, the success of this meeting is you tend to bring very good international guests, 4 very good internationals, plus some colleagues from Hong Kong at this meeting, and we're going to chat to them on the podcast. But also some fantastic talks from expert leaders here in China. So I want to first of all ask you about your talk today. You covered a whole lot of stuff in prostate cancer, and in particular these new robots. You've been very involved in all sorts of clinical trials in GU Oncology, but you are doing some trials with some of these new Chinese robots. Can you tell us a little bit about the academic progress?
Okay. This is the robotic you just mentioned. Also, this morning I shared with the colleagues this morning's conference is the modulated, robotic surgery system. It's just designed and made in a local Shanghai, company. It's a biotech company, and this is the interesting robotic. It's not the Da Vinci way we just follow. This is the called the modulated,
different arms,
different cart, and also this is the interesting system. Is not only is an advantage for the GU cancers, also can spread out to other field like GI, gynecology, even thoracic surgery system, because this is more can get used to the Da Vinci system is only it's integrated. All the arm integrate together. It's better to perform procedures in a very limited spaces. But this modulated is docking is more easy. And also you can perform the procedure. It's a wide space, like the GI or even the renal, kidney cancers, even the
chest,
pelvic, chest. This is better.
That's definitely something we're looking forward to in the next year or two, is watching this wave of Chinese developed robots coming out, as I spoke about in one of my lectures today. Well, look, congratulations on the meeting. It's great to be here and to have GU Cast here bringing highlights of the meeting, and we look forward to helping spread the word, and people should come to Shanghai in December next year for this world-class GU Oncology meeting.
Thank you.
So we're joined by one of your international guests, Professor Karim Fizazi, GU medical oncologist from Gustave Roussy in Paris. Welcome, Karim.
Thank you. Thank you to both of you.
Have you been here before in Shanghai?
Actually, never in Shanghai, and first time in mainland China. I went to Hong Kong long time ago, but first time here in China, in mainland.
So it's great to have you.
Thank you very much. It was a really great experience.
So what we wanted to speak to you a bit about was the PEACE 3 trial, which of course was one of the really big trials that read out in ESMO this year, just a couple of months ago, because you were the discussant on the trial. And of course, you've been very involved with all of the PEACE consortium of academic trials. So before we talk about PEACE 3, and it is a practice-changing trial, no doubt about it, that Silke Gillison read out. Tell us a bit about this PEACE consortium, because they've been very, very successful. And
Sure, actually more successful than what I thought when we launched it 10 years ago. The general idea was really to make sure that European countries could join forces when it comes to doing academic work, mostly phase 3 trial, for men with prostate cancer. So really PEACE stands for Prostate Cancer Consortium in Europe. And obviously non-European countries are welcome to participate. So the rule is really to have at least 2 European countries working together for a phase 3 trial for men with prostate cancer in different settings of a disease, localized, recurrences, metastatic disease, resistant, etc., etc. And when really we launched it, the idea was to make it easy for these countries to work together. 10 years later, I think it's just fair to say it's a success. We now have 10 phase 3 trials out of the ground,
Great.
either completed, phase 1, piece 1, piece 2, piece 3 obviously have completed accrual, piece 5 as well, or accruing patients right now, or just about to start in the coming weeks. So I think it really worked very nicely, and it really helped to have people working together and better understanding each other.
Yeah, well, congratulations. And of course, big pharmaceutical companies can do phase 3 trials. They have a commercial interest, but running phase 3 trials for academic groups is very challenging, isn't it?
Yes, it's wonderful to have the Peace Consortium to run such a practice-changing trials, and especially the Peace 3 combine radium-223 with enzalutamide really improves the survival. And the point is that nowadays we have more and more patients with de novo metastatic prostate cancer treated with novel antigen at diagnosis.
Right.
So what's your opinion about the clinical practice recommendation in the nowadays patients?
With the Peace 3 data.
Yeah.
So yes, again, just to summarize, in Peace 3, adding radium-223 to enzalutamide actually postpone progression. RPFS is improved, but also overall survival is improved. Having said that, it has to be in a context where denosumab, ozolinic acid, is being used to prevent fractures. But you're very right. When Vestral was invented, this was really back 2015. At this time, we were not using AR pathway inhibitors for hormone-sensitive disease. So the data that we now have in P3 may or may not, of course, apply to all the current patients who, when they develop CRPC, have already exhausted at least one of these agents, abiraterone, enzalutamide, apalutamide, or darolutamide. Whether the data, the favorable data from P3 apply to the current situation, at least to these patients, we just don't know. This remains to be demonstrated. Having said that, actually many surveys still indicate worldwide that unfortunately many men with advanced prostate cancer still receive ADT alone before they develop castration-resistant disease, meaning that for these patients, the P3 data actually apply. So at least for these men, P3 is great news because it's another opportunity to postpone death.
So it's clearly practice changing, just for audience out there. If you have a patient who has started their ADT for metastatic disease and they've progressed and you're thinking of an AR pathway inhibitor, enzalutamide for this trial, if you have access to radium, and hopefully that's what will start happening next year, reimbursement and so on, yeah, clearly that it should be an option for patients. But you did emphasize in your discussion at ESMO that the bone-protecting agents are important. Yes. Can you remind us of why that's an issue? Why everyone's going, but what about the bones?
Yes. Actually, it's a kind of nice story. Bad story initially, and then it switched to a nice story. Bad story because actually this is not the first trial. The first trial was ERA-223, which was combining abiraterone with radium. And not only the trial was not positive, but it was actually really negative. Meaning that patients in the combination arm actually develop more fractures with a trend for worse outcomes by overall survival. And indeed, when you think about it, if you're using potent hormonal therapy to the bone, you might induce potent osteoporosis. And if you irradiate a frail bone, it might break. Yeah. And actually, this is very likely what happened in ERA-223. So when the data came out back in 2019, at that time, P3 was ongoing already. And I think the chairs had two options, either stopping their trial to avoid repeating what happened in ERA-223 with an excess in fractures clearly indicated in the trial, or amending their trial to make denosumab ozolinic acid mandatory for the next 2 patients in the trial. And they chose actually this B option, which was a smart move. Indeed, not only the trial showed that the incidence of fracture is diminished dramatically after the amendment. It's really impressive, from approximately a 50% incidence at 2 years in the combination arm, 25% still with enzalutamide, to almost zero when these agents are being used in a context where denosumab is also being used. So that was by its own a very important information to, I guess, to all of us for our practice. But also overall survival and progression-free survival clearly favored the combination arm. So I agree with you. I think it is practice changing.
A good story.
So
It is.
it's kind of the triple treatment. Enzalutamide, radium-223 combined with bone-protecting agents to generate such a wonderful outcome.
I agree. And actually, in some patients, it should be a quadruple.
Yeah.
Because, yes, because enzalutamide, as opposed to what we thought some 10 years ago, is associated with significant hypertension in some patients. And P3 confirmed this. And this was true in both arms, by the way. So we need to monitor blood pressure and we need to treat. So you should be a cardiologist, and same to myself. Of course, we should ask all our cardiologist colleagues to help us if needed. But whoever prescribe, we should,
Blood pressure.
yes, treat the hypertension.
Really good. And finally, Ju, here in China, what's the current situation with radium? I have to say in Australia, we don't use it very much, but now we'll see how that changes. But is there access, and do you think this will be in clinical practice here now because of Peace 3 for that population?
After the publication of the Peace 3 data, and we are more and more likely to move the radium-223 in an early stage of prostate cancer. And as Karim just mentioned, nearly half of our patients were treated with ADT alone at diagnosis. So we still have the perfect patient population most likely to benefit from this combination. And the 2 points you mentioned, what makes P3 successful is one is to bone protection, and the other one is control the high blood pressure. And this 2 point, I think, is really an important point and will be impactful in our clinical practice.
I think they are.
For sure. Congratulations to Silke Gillison and Bertrand Tombal and all the peace investigators. That's really wonderful stuff.
Absolutely.
Congratulations.
Thank you so much. So I'm joined now by Professor Peng Wu, a urologist here in southern China. Peng, thanks very much for joining us.
Yeah.
Can you please introduce yourself and tell us a bit about your institution and where you come from?
Okay, thank you, Dr. Murphy. Actually, I'm a big fan of you. I'm from Nanfang Hospital, South Medical University. It's located in the south of China, Guangdong Province.
Fantastic. And yes, you've told me you are a regular listener or viewer to GU Cast. So yeah, we really appreciate meeting our Chinese audience.
Yeah, of course. Yeah.
Now, what we want to talk to you about is in your region, you actually have an early detection program, a prostate cancer PSA testing program.
Yeah.
And in Australia, in our country, we have a lot of just opportunistic use of PSA testing, but we don't have like nearly every country, we don't have an official or a standardized training PSA testing program. And I know generally across China, a lot of patients present with metastatic disease because there's not much awareness of PSA testing, especially in the regions. But you have a formal screening program, I think, in your province in southern China. So tell us a bit about that and how it changes the way men present with prostate cancer.
Okay, thank you. Actually, PSA screening, we don't have the government-led PSA screening program in China, the same as Australia. As you know, the prostate cancer has been increasing public health program in recent years in China. We have data in 2015, the incidence of prostate cancer is about 10.2 per 100,000 patient.
10.2.
Yeah.
In Australia, it's about 120, I think.
Okay. So, but in 2022, it's about 18.9.
Yeah,
increased very much. But unfortunately, in China patients, when we find the prostate cancer, is most of the time is in the middle or the end stage of them. And the 5-year survival is only 69.2%. So, it's very low compared to
the main message is a lot of men presenting with very advanced disease, and despite the advent of therapies, the problem is it's already a very advanced state. Yeah,
of course. So early detection is very important for us.
Yeah.
But as you know, we don't have the government-led the PSA screening program. So we're trying to solve this program by ourselves. So we just started this program at 2019 with some local community health center. With our hospital, we just screen about 2,000 or 3,000 patients per year for that. including patients about 50 years old.
Okay, you start at 50.
Yeah. All the patient, the PSA level is over 1 nanogram. If he is in his 45 years old, or he has a PSA, the prostate cancer family history is if the patient is over 45 years old. We start all this PSA screening for them.
And so, how do you find these 2,000 or 3,000 patients? Do they get like a letter into their mailbox or email, or how?
No.
Yeah.
We collaborate with a health center.
Okay.
Yeah, community health center. Yeah.
Health. Okay.
Yeah, in our district we have about 200 million people in our district.
Okay.
Yeah. It's just 1 of 10 district in Guangzhou city.
Yeah.
So we just collaborate with this health center. We just tell them we have this program, and they invite people to come there. If the patient want to join the program, they just make a consent of that. And we have a digital platform. They scan the QR code and register. And the medical center, the health center, will give them the blood test and send out to a hospital. And we get the result and send back to them.
Okay, so therefore, and it's an academic program, you're gathering the data. So what's the impact? What are you sort of seeing in these patients?
Actually, we find the PSA level is abnormality is the most abnormality is in over 80 years old. It's about 20%. And from patient from 70 to 79 is about 15%. But also patients from over 40 years old, there's about 8% abnormalities. But unfortunately, only maybe 20% of them they want to they want to do the biopsy of them. So I think in 2022 we find about 34 prostate cancer patients of all these people. But I think because not all of them do the biopsy, so maybe it's not the true the data from the screening program.
And of the ones you biopsy, are you finding that there's a high proportion that have localized disease?
Yes, of course.
Yeah.
I think maybe 60% of them are local prostate cancer. Yeah, so I think it's a very meaningful program for that.
And do you think other regions or other parts of Guangzhou city and the surrounding province might look at the program and say, oh, maybe we should expand it to our district? Do you think
it will be in Guangzhou, I think most of the districts, they have the program, but not for all the city in China, because, Guangzhou city is an economic developed city. Powerful city. The Pearl Delta region. And also, the Yangtze Pearl Delta region, for example, Shanghai is located here. And Beijing, we have abundant medical resources. So the program can be carried out. And we have abundant supply funding for that. But China is a very large country. So how we can start the program all over the country is a big problem.
And especially when prostate cancer is not the only problem, and out in the regions, there are many other health problems, aren't there, that perhaps are higher priority. So, we prostate cancer enthusiasts always understand that there are limited resources. But nonetheless, I think it's very important here in China that regions like yours are doing this in a community fashion and collecting the data and writing the papers. So at least you can point towards your own patients and say, well, this is the impact of inviting patients in a really easy manner. You're making it easy. People are used to scanning QR codes. It's very popular here in China. So you have a good mechanism, a good process for trying to encourage patients.
Actually, we built up a software platform. So the hospital and the community health center, we can share the data together and makes it more efficacy and transparency. And the patient get some information from that. If we find the result is abnormality, so the community center will send a message to them and ask them to come to our hospital, and we give them further detection, the advisement for them. If the PSA level is less than 4 nanogram, we just advise them come here 2 years later. If over 4 nanogram per milliliter, they just give advice to come out to our hospital. But we give them a green eye or two to see us.
So make it easy. Right, great. Well, look, Peng, thanks very much for coming to speak to us on GU Cast, and thank you for being an enthusiastic supporter. We really appreciate your support.
Okay, thank you so much, Dr. Murphy.
No problem.
Thank you.
And another great international guest, I think this is his first time in China, Professor Axel Merseburger.
Great to have you.
Thank you. Thank you for invitation. It's really my first time and a great experience. Thank you for hosting.
Yeah.
And you're a friend of the podcast. You've been on GU Cast many times in all sorts of different countries, including Australia already this year.
Yeah.
At your house, it was exciting.
Very
Thank
good.
you.
And Renu sends her best wishes. I'm sorry she's not here. She's in Esmo, Asia this weekend. But yeah, look, great to have you. We wanted to pick your brains for a few moments about these two big darolutamide-based trials, ARASENS and then more recently ARANOTE, because I know you're very experienced in running metastatic prostate cancer trials. And they both kind of refer to one of the hot topics we have, which is triplet therapy, ARASENS, and doublet therapy, which is ARANOTE, plus all the other ARPI ones. But so first of all, about ARASENS, which was a pivotal randomized trial comparing ADT plus docetaxel with ADT docetaxel plus darolutamide. So can you give us your sense of where ARASENS fits now in our armamentarium of metastatic hormone-sensitive prostate cancer?
Well, Declan, I think it is very fair to discuss with our patients the options we have, and I think it's doublet or triplet, and we have no head-to-head comparison. However, we have good trials like Titan and Archer's trial and ARASENS trial that has delivered overall survival benefit in this situation for our men with MHSPC, the patients that suffer of metastatic hormone-sensitive prostate cancer. So I think it is very important to optimize the treatment with at least a doublet and no ADT monotherapy, or in some cases, for example, young patient age, aggressive disease, poor genetics, and high volume, high risk, a triplet at the beginning. So an all-in approach at the beginning to get a good response. And now we have data from doublet darolutamide as well. So it's really not so easy to decide what's best for our patients.
But I thought that was a very clear message he gave us, is that for the vast majority of our metastatic hormone-sensitive patients, and I know we keep going on about this on GU Cast, but it's so important we still get the message out. We should not be using ADT monotherapy. Unless you have some other really good excuse, there should be something additional. And if you're in a country where there's an ARPI reimbursed, it should be an ARPI. Yeah. But here in China, I know there's a lot of advanced prostate cancer, and you have darolutamide established already within this ARASENS setting. So it's for patients who are starting ADT, docetaxel, and you add in the darolutamide. So what's your sense on before we talk about the doublet of darolutamide, what's your sense of how that's being embraced here in China?
Yes, so in China, we do not have PSA screens, and nearly half of our patients, they have the advanced stage disease at diagnosis, and we're really happy to see the data of ARASENS and ARANOTE come out. And to us, the important point is that nearly half of our patients are more than 17 years old. So when we see the ARASENS data, we are trying to figure out the definition of the chemo fit. As you have mentioned, that the young patients and the patients with high performance state, low performance state, high performance status to treat it with ARASENS triplet treatment. However, we do have some patients with fragile status, and they have poor performance status after the kind of the triple treatment. So we are really welcome the ARANOTE data to see the possibility of intensified treatment in this space. So actually, I have a question. How to define the chemo fit definition in your clinical practice? Which is some of the, the clinical factors you are taking into your decision to define, predict the patient will have a nice performance status during the triple treatment? I
have to say that's such a good question, because just for listeners out there, Axel's a urologist like us, but as is the tradition in Germany, your unit look after the systemic therapy with the docetaxel. So you're a good person to ask that question before all the medical oncologists out there going, why are they asking a urologist that question? Well,
thanks, Declan.
In Germany and in Canada, urologists.
Sure, and even in China, I've learned the last couple of days. So I think that's really exciting. And I think the question is really, it's a tough question, but the easy answer is it's not age dependent. So you can have an 80-year-old that is fit for docetaxel, for chemotherapy. So I think it is something you discuss with the patient. Renal function plays a role. It's a geriatric assessment, what we do once in a while, like a short geriatric assessment. And then definitely when you have other options, maybe you spare the chemotherapy. And nowadays we have radioligand therapy, in the future MCRPC treatment. We have also PARP inhibition and combinations. So maybe we could even have some men that could spare out the chemotherapy. But definitely, if you want to get it in most men, you can get it. You can give it to the man, and it's not like you can still stop after a while. You can say, okay, how does the patient tolerate the chemotherapy? How is the renal function? How's the liver function? And then decide upon, after a couple or 3 cycles, how to decide. How do you do this?
Yes, so we are
Give this tough question back, because it's not so easy.
So we are glad to have 3 medical oncologists in our department and work very similar to Axel, and we can refer the patients who have to be treated with docetaxel to them, and then we'll monitor very closely, just as you have done in your patients, and we may stop the chemotherapy if the patients have some like grade 4 AE after the chemotherapy, and it will I think it's a nice cooperation between the urologist and the medical oncologist to improve the patient's outcome.
Okay, now we want to stop talking about chemotherapy now, you two, because that was just to get us warmed up for darolutamide in the doublet setting. Because as regular listeners and viewers will know, I'm not a big fan of triplet. I keep saying the same thing. I know you sometimes disagree with me, Axel. I still keep making the point that there's no evidence that adding docetaxel to a RP doublet improves survival and so on. But in the darolutamide patient population who tolerate darolutamide very well, we've been sort of handcuffed to the triplet, haven't we? And then at ESMO this year, our note read out. We won't go into all the detail of it, but in summary, it's a doublet, ADT plus darolutamide compared to ADT alone, much like all the other trials, Latitude and Titan and so on. Just confirming for us that that's a significant option and improves RPFS for these patients. So can you take us into this era that we're now in with darolutamide available as a doublet as well?
Yes, definitely. And I think it's exciting, and I think we all have been waiting for this data since now it's the 4th option we have. If regulatories we have Titan trial, we have ARASENS trial, we have now the ARANOTE trial, and we have, for the doublet Latitude trial. And so we have options for a lot of RPs right now. The question is which one is the best, and I think you cannot compare the trials among each other. So you really need to look at the trial results, and there are different patient population, also different times and different times, countries where the trial has been run. But I was excited to see the data because, as you said, darolutamide has a relatively good side effect profile, and I think most exciting is the drug-drug interaction, which makes it very comfortable. And so if you have the triplet on the one side, and you're asking me about chemo eligibility, so the doublet would be probably an all-comer option for a lot of men with MHSPC.
And finally, to you,
I totally agree.
You'll agree with that, I'm
yes,
sure.
Because one of the medical oncologists, he told me that if you are concerned about the drug-to-drug interaction, just choose darolutamide.
Okay.
It has the lowest risk to interact with other drugs to generate some side effects. So this is a very nice point to be mentioned.
So as this data now has emerged here in China, do you think you'll see a move from triplet ARASENS type patients into a really big shift? The vast majority of those ARASENS patients, do you think they'll just be on doublet RP?
Yes, so most of our patients, they are willing to treat with the drug and do not like to receive the docetaxel chemotherapy. And another point to be mentioned is that the ARASENS and ARANOTE, they also include Chinese patients.
Yes.
And it's do not like the P3 trial, they recruit most of the European or the United States patients. The ARASENS and ARANOTE, they have many Chinese patients, so we can have the Chinese subgroup analysis to define the efficacy and also the side effects of these patients. So this makes the treatment into the clinical practice more rapidly. So this is another advantage to be mentioned.
And it'll be back to your opening point, Axel, that more and more men will be getting some sort of intensified systemic treatment up front, which is great. Well, thanks very much, and hope you're enjoying life in Shanghai, by the way. It's your first trip to China, I think.
Yes, indeed it is, and very exciting. And maybe just a comment, I try to avoid intensifying because it sounds like intense side effects. Yeah. I was taught by a prominent oncologist from the UK, Amit Bal, that you should rather talk about treatment optimization. You know, like it's not getting for the patient. It also sounds a little better. Just, but thanks for inviting. It's just it's a pleasure.
It's a good pleasure. Thank you.
Thank you. That's it for part one of our GU Oncology highlights from Shanghai. I hope you enjoyed that. We'll be back very soon with part two of the conference highlights from this year's Shanghai GU Oncology meeting. Thanks once again to our conference highlights partners, Bayer China.